tonight's speaker was unable to attend. And in a moment's notice, tonight's speaker stepped up. He said he would take care of us, and he's going to talk to us about why shock kills. And one of our at-large board members, Steve Mercer, has stepped up for us tonight. Steve's been in EMS since 1974. I was a sophomore in high school. I don't know if that was information anybody needed, but he's a voting member of the National Council of State EMS Training Coordinators for more than 10 years. As a representative, he served as a vice chair and treasurer, a member of the National Review Team for the revision of the EMT, Intermediate, and Paramedic National Standards Curriculum, the National Registry of Emergency Medical Technicians Practice Analysis Test Project, which I know that he was very proud of that project, and the EMS Instructor Task Force. He was the trauma section group leader for the revision of the EMT Intermediate and EMT Paramedic National Curriculum, and a technical writer for the EMS Education Agenda for the Future, which was a National Highway Traffic and Safety Administration document. He served on the board of directors of the National Registry of EMTs and a NASA Space Medicine Work Group member, helping them figure out how to take care of emergencies in space. He was appointed to the International PHTLS Committee, Executive Committee, where he served for more than 20 years. He has 23 publications, including technical contributor for medical care for astronauts in space, a medical education program for crew medical officers, author, editor, and contributor for 5 editions of the PHTLS textbook and the instructor manual. He's also a director with the International Pre-Hospital Medicine Institute. He was awarded the PHTLS Achievement Award in 1999 and 2000, Professional EMS Instructor of the Year Award, and an Iowa EMS Hall of Fame inductee. He retired as an executive officer from the state of Iowa EMS office in January of 2022. So with that, I'd like to introduce to you my friend, and actually a friend of all pre-hospital care providers all over the world and their patients, Mr. Steve Mercer.
Well, thank you very much, Mary. Thank you for allowing me to be here this evening. And also, I want to take time to thank everyone that's participating here tonight, taking time out of your family life to be here. So, again, as Will indicated, one of the things that we do ask is that you remain muted throughout the presentation. And if you have any questions or comments, please use the chat feature. Will monitor as we go along. If anything comes up that needs immediate attention, he'll let me know. If not, we'll address everything at the end of the presentation. So as Will indicated here, just a second, I'm going to get things started here. Okay, you all should be seeing my screen now. Okay, good. Well, what I want to talk to you tonight is maybe give you a little bit different approach to something. We've all heard lectures on shock and everything, but one of the things that used to get me in trouble when I was when I was working and everything was I kept asking why about certain things, and it would get me in trouble, keep me in trouble sometimes. And one of the questions that I think that we all know that shock kills, but why does it kill, and how does it kill? And so what I want to do tonight is maybe take a different look or ask you some different questions in regards to this and have you take a different look and perspective on why shock kills. So we'll get by that. I have an opening question for you. If we were to ask you, and again, we've asked this question many times of individuals throughout our career and everything, how would you define or identify shock? And for the most part, we receive the same continuous answers and everything. People will define shock as well. The patient's got a low blood pressure, a rapid pulse rate, cold, clammy skin, things like that. That's actually not shock at all. What it is you're defining an indicator or systemic manifestations of the process, but it's not really shock. If we want to give a definition that's probably a better definition of shock, it's a decrease or lack of tissue perfusion or oxygenation at the cellular level that leads to anaerobic metabolism and loss of energy production. Energy production was a passion of Dr. McSwain's, and he persuaded us to pursue this, and along with another colleague of ours, Dr. Peter Pons, we put together this information here on energy production. And it gives you a different perspective on shock and how the body deals with a lack of perfusion. I use this picture here just to remind everybody about the circulatory system. The circulatory system has three basic components. It's got to have a pump, it's got to have fluid, and it has to have a container. And all of them has to work harmoniously in order for the circulatory system to be able to provide perfusion to the body. So keeping that in mind, we'll talk about some changes here. The first thing is, let's take a look at the basic types of shock that we see out there. Any condition that causes decreased cellular perfusion and energy production can be defined as shock. And we see typically three different categories. We see hypovolemic shock, and hypovolemic shock is related to the loss of circulating fluid volume. Distributive shock is associated with container size. When you look at this neurogenic shock, it causes the vessels to dilate and decrease the pressure that's inside there, and it causes a lack of oxygen being able to be delivered to at the cellular level. Cardiogenic shock is another one that causes the pump to decrease its cardiac output, and along with that decreased cardiac output, it causes lack of oxygen again to be delivered at the cellular level. Intrinsic types of cardiogenic shock are those that weakens the cardiac muscle or the contractility of the muscles. And then the extrinsic would be things that you usually see associated with trauma, such as cardiac tamponade or tension pneumothorax. When we talk about trauma-related shock, again, hemorrhagic shock is from blood loss. It causes decreased circulating volume. If we have a decrease in circulated volume, that also means that we have a decrease in the red blood cells being transported or being circulated throughout the body. And then that decreases the ability of the cells to receive oxygen from the circulatory blood. From a distributive standpoint, especially neurogenic in there, this is a law of central control. This has two systems that it's going to affect. Neurologic can affect the respiratory system, and then it can also affect the vascular system. If we have, remember that our vessels stay in a half-constricted state. It's called vascular tone. If we lose that vascular tone from an interruption in the nervous system, it causes dilation of the vessels. If we have a dilation of the vessels, that means that we have a decreased pressure in there and a decreased ability to deliver oxygen to the cellular level. If we, on the other hand, we have an increase in vascular tone where it causes vasoconstriction, it decreases the amount of flow and decreases again the ability for the body to deliver oxygen at the cellular level. Cardiogenic, again, we kind of already talked about, it's a pump failure. So with intrinsic, and we typically see this in extrinsic issues with the trauma patient. But again, those three components that we talked about, the basic components, we have a pump, fluid, and the container system of that. We all remember these formulas. These formulas help us as we do our assessment of our patients. And if we just remember, cardiac output equals heart rate multiplied times stroke volume. Stroke volume, again, is the amount of blood that's pumped out of the heart in one cycle. So you can see that here, cardiac output equals heart rate times stroke volume. And then blood pressure equals cardiac output multiplied by the systemic vascular resistance. So that vascular tone that we talked about in there. And again, you can see the formula through there. If we use these guides with us as we do our assessments and everything, that's going to help us do a lot with our patients in there. And in order for this to be effective, we have to do repeat continuous monitoring of our critical patients in there. So having said that, let's go on. Let's talk about now perfusion and energy production. What we're beginning to talk about in there, a different look at stroke. Okay, so those of you that knew Dr. McSwain, he had a tendency to pronounce some words in his own version, and perfusion was one of those. In Normanese, it was profusion, and that's exactly how he wrote it in there. So those of us who had the pleasure of writing with Dr. McSwain, that was always a constant issue. So let's talk a little bit about perfusion. Again, perfusion is the passage of fluid through the circulatory system to an organ or tissue. And it's usually referred to the delivery of blood to a capillary bed located within that tissue. In order to achieve adequate perfusion, we have to have a significant amount of circulating blood that's enriched with oxygen, reaching the alveolar beds so they can offload at the capillary beds to gather and remove waste products. As a rule of thumb, when we talk about perfusion, we can estimate that a patient probably has decent perfusion if they have a mean arterial pressure that's greater than 70 millimeters of mercury. So most of you are saying, well, I can't measure mean arterial pressure in the field. Well, here's a little quick formula that you can do that will give you an idea of that. Mean arterial pressure is actually the diastolic blood pressure plus 1/3 of the pulse pressure. So you take the diastolic blood pressure and add 1/3 of the pulse pressure, and that will give you a very close estimate of what the mean arterial pressure is for that patient. If it's 70 or greater, then we probably have a decent amount of perfusion occurring at that point. Okay. Now, again, the supply, and when we talk about supply, we're talking about the oxygen being delivered at the cellular level through the blood, has to meet the demand in order to achieve adequate perfusion. The patient's mental status is one of the earliest things, indicator that we're having a decrease in perfusion. So again, constant monitoring and constant assessment of the patient is going to help us identify this as early on as possible. So some of the principles about perfusion and diffusion principles. It's a combination of work between the respiratory system, the circulatory system, and the neurologic system components. Each system has to be intact and functioning properly. And again, to remind you that diffusion is the physical process that refers to the net movement of molecules from a region of higher concentration to one of a lower concentration. Okay, so these are the components that we're going to talk about here as we talk about getting perfusion going throughout the body. So again, offloading of oxygen to the red blood cells. Diffusion moves the oxygen molecules from the higher concentration of the lungs across the alveolar capillary beds to the lower concentration of the hemoglobin molecules. The average adult has approximately 20 to 30 trillion red blood cells circulating in their body. RBCs have a lifespan of approximately 120 days. Old RBCs that have lasted longer than 120 days are usually broken down by the liver and the spleen, while new RBCs are manufactured in the bone marrow. So if you think of the RBCs as a big bus transporting hemoglobin, each red blood cell contains approximately 270 million hemoglobin molecules. Okay, so each hemoglobin carries 4 molecules of oxygen. So in essence, each red blood cell will carry over 1 billion oxygen molecules. That's how oxygenated our body is and how much it depends on oxygen. When you think about that, you got 20 to 30 trillion red blood cells, and each blood cell carries over 1 million oxygen molecules to it. Okay? Now, the other thing to keep in mind here, when we talk about red blood cells, remember about 41% of the circulating blood volume is red blood cells. So when we begin to lose red blood cells, we lose the ability to provide oxygen at the cellular level pretty dramatically in there. So as we transport the RBCs, again, after we load them up with oxygen from the higher concentration of the lungs to the circulating volume, now we have to be able to transport it to those cells. We have to have an adequate amount of fluid to move these RBCs. The average adult has approximately 5 liters of fluid within their body, the circulating blood volume. The vessel's container has to be of an adequate size in order to properly allow fluid and red blood cells to progress through it. When we offload the oxygen at the cellular level, there has to be an adequate amount of time for that transfer to take place. Okay, so we offload from the higher concentration of the red blood cells in the hemoglobin, the red blood cells, to the cells themselves. Remember, diffusion, higher concentration to a lower concentration. After we offload the oxygen, now what has to happen is we have to onload back onto the circulating to the circulatory system the waste that's been produced in the cells. Now, this waste again is accumulated through production of energy.
There was a midget on our cruise.
Was there? Was he a wrestler?
It was a girl.
Oh.
Okay. Mary's iPhone. Thank you. Okay. Again, there has to be an adequate amount of time for this to occur. One of the things that you start seeing again, in patients that are experiencing shock and everything, they start seeing a more rapid inspiration and expiratory phase in there. Remember that the more rapid their inspiration, the less volume they're going to bring in. And then the less ability they have to bring in good oxygen into there. So that's going to be, again, an indicator for assisting with their ventilations in there to help get an adequate amount of oxygen there and an adequate amount of time for offloading and onloading to take place at the cellular level. So again, offloading. Now our circulating blood volume has all this waste volume in it. And as it comes back into the lungs, it's going to, again, diffuse into the lungs from the blood system because it goes from a higher concentration to a lower concentration. So that can be eliminated through the expiratory process, again, through the expiratory process of breathing. Okay, let's talk a little bit about how energy is produced again. And this is just, again, more of a review process. Remember that metabolism is a process converting food into energy. It powers all the body functions and sustains cellular and organ functions. Remember that the body contains over 100 million cells, and each cell requires an adequate amount of energy to function normally. Okay? So cells generally create energy from oxygen and glucose. Well, we know how oxygen gets into the body, but now we have to worry about glucose. Remember that insulin is released from the beta cells of the pancreas, and that allows for the glucose to enter the tissue cells from the bloodstream. So the combination of glucose and oxygen is what's used to create adenosine triphosphate or ATP molecules. This is the energy that the cells need for to function properly. This is broken down and stored as energy when needed by the cells. Without energy, cellular functions cease and eventually death can take place. Our goal, again, is to help ensure that the patient's body maintains adequate energy production and perfusion, both. So we have to make sure not only that they have an adequate amount of oxygen and glucose in there, but also that they have an adequate ability to perfuse. So that means the circulatory blood volume has to take place. So in order for all this to work, we can have 4 systems that need to work together, okay? We have to have an intact and functioning nervous system. We already talked about the nervous system controls the respiratory centers in our brain. It also controls the vascular system, the size of the vascular system or the container in there. We have to have a patent airway in order to get an adequate amount of good oxygen into the body. We have to have adequate breathing and ventilation to achieve this so that we can, again, get this oxygen to the cellular level. And then we have to have an adequate amount of circulation through circulating blood volume in there with an adequate amount of red blood cells and hemoglobin that's enriched with oxygen in order for perfusion to take place. So another way to explain this, and I found this is probably one of the easiest ways to explain how this works, is if we take a hybrid car. Most all of you are familiar with a hybrid car. It utilizes both a electrical engine and a gasoline engine. In the hybrid car, energy to move the car comes from one of 2 systems. Again, the primary, which is the electric system, or the backup, which is the gasoline system. The first, or the primary system, is electrical motor. It creates an adequate amount of energy and a great amount of torque to move the vehicle with little to no waste product. Plus, it also stores additional energy. Those of you with a hybrid vehicle, you can usually click on something on your instrument panel, and you can see how the energy is being produced in the battery and then being stored back into the battery in there. Now, in the failure of the electrical system, of the primary system, or after you reach a certain speed and everything, the gasoline engine takes over. Now, the gasoline engine, it will produce energy to move the vehicle forward, but it's not the same amount of torque as what you'd see with the electrical system. And it has an increased amount of waste product and no backup. Okay? And no backup in energy. So our body has a primary to backup system also for metabolism. Okay, we have the primary system, which is aerobic metabolism, and then we have a backup or an anaerobic metabolism process for energy production. So let's talk about each one of these when it comes to energy production. Aerobic metabolism, it's the most effective method for energy production. Simplified, it uses oxygen and glucose to produce energy through a chemical reaction known as glycolysis and the Krebs cycle. And again, this is simplified. It produces the largest amount of energy. With each cycle, it produces 36 molecules of ATP. Now, that's in each cell. And the cell, again, will store this and utilize this when it's necessary. Waste product from here is CO2 and water. And again, we saw how that's eliminated out of the body as it collects. So a visual representation of this would be like this. We have 6 molecules of oxygen and 1 of glucose. Remember that the mitochondria is the work section within the cell. This is where we're going to produce our energy. So once we take these elements of oxygen and glucose, move those into the mitochondria, here's what we end up with. We end up with 6 molecules of CO2 as waste, 6 of water as waste, but we have 36 units of ATP that's been produced through here. The other thing that's produced that becomes important to us is heat. If you look here, there's 417 kcalvins that's produced with each cycle within the cell as it produces energy. Now, aerobic metabolism has a lot depends on it. You have to have a functioning neurological system, again, because of what we talked about with the respiratory component of it, as well as the vascular component of it. An adequate continuous supply of oxygen. So this is where we have to have the patent airway and functioning lungs. We have to have the functioning heart in order to pump the blood in the cells. Intact and proper sized vascular system. Again, as we talk about, and we'll talk about it here in a second, excuse me. One of the ways that the body compensates during hypoperfusion is it starts shunting blood. And what it does is it moves blood, it causes vasoconstriction. And the vasoconstriction will help to keep the blood pressure up, but it also decreases the amount of flow. Decreased amount of flow means decreased amount of red blood cells available to carry hemoglobin to those cells. Now, again, clues of treatment is going to be based on your assessment findings in there. But if you look at these things here, this is what we want to focus on in order to maintain a true aerobic metabolism process. Now, anaerobic metabolism. Any injury or disruption that affects any of the components of the oxygen delivery system will affect perfusion and energy production. Again, all 4 of those components that we talked about previously. Anaerobic metabolism is a metabolic process that functions in the absence of an adequate amount of oxygen for only a short time period. And again, those of you going back to your medical terminology, you see here, this means without, okay, aerobic, so without oxygen, metabolism without oxygen. So in this case here, we still have some glucose that's in the body. And once it enters the mitochondria, what's going to happen here is we're going to have a development of lactic acid. And as you can figure out, anything with the name acid in it is not good for the body. It produces 2 units of ATP in comparison to the 36 that we saw with aerobic. But also notice the heat from 417 kcalvins to 32. So again, a tremendous decrease in the amount of heat as well as ATP in there. So again, we have metabolism without adequate oxygen supply. The cells use stored glucose in the form of glycogen for energy production when it doesn't have the ATP in there. It's anaerobic metabolism. The body is capable of sustaining energy requirements only for a short time period. So anaerobic metabolism produces only small amounts of energy, a 19-fold decrease in ATP production. Okay, increase in acid and decreases heat as byproducts. Any of these things over here that you see on the right-hand side are things that can impair or disrupt the aerobic metabolism process within the body. So what are the consequences of hypoperfusion? Okay, obviously, again, cellular hypoxia, decreased inadequate ATP production, dysfunction of the cells, hypothermia. The rate of when we talk about trauma patients, again, the rate of hemorrhage will impact the degree of physiological changes that we see within the body. But the one thing that is very easy to detect is just to pay attention to the heart rate. Tachycardia in a trauma patient should be a strong indicator of shock, especially, and this is people refer to it as shock index, if the patient's heart rate is greater than their systolic blood pressure, there's a very good indicator that the patient's probably in shock. So again, if their heart rate is greater than the systolic blood pressure measurement, there's a good indication that that patient is in shock. Now, increased acidosis will also cause cardiac dysrhythmias and decrease cardiac output. It'll decrease the heart's ability to contract. So those are those intrinsic issues that we were talking about earlier in cardiogenic shock. But hypothermia is the one that we forget about sometimes. And again, because we have the body does not produce as much heat in their production of energy, the patient can become very hypothermic. Now, the body has a response to that too. The body will start shivering to produce heat. As the body shivers to produce heat, it increases the rate of energy consumption in the body. So it's kind of a vicious cycle. We'll talk about that here again just a little bit. But again, you get cellular dysfunction, you get autodigestion of the cells, which is going to lead to organ failure. We have entry of sodium and water into the cells, which can cause swelling of the cells and overhydration. This is a continuous cycle unless oxygenated red blood cells reach the capillaries. So with any further loss of a blood vessel, the cycle continues. Again, if you look over here, remember that we said that 41% of our blood volume is red blood cells. And we talked about how much oxygen is needed to keep the body functioning in a normal tensive state in there. So as we begin to decrease our blood volume and everything, we're decreasing the amount of red blood cells tremendously in there. That's one of the reasons that we see blood products being utilized in the field more. But the other thing about it is one of the things, well, if the patient has low blood pressure and everything, what we'll do is we'll just pump them full of fluids. Well, while infusing copious amounts of crystalloid fluids can increase the patient's blood pressure, there's a lot of disadvantages associated with it. Number one, crystalloids have no oxygen carrying capabilities. Overhydration of the cells, and you can overhydrate them to the point to where the cell ruptures. Once a cell ruptures, you can't repair it. A dehydrated cell you can repair. A cell that's ruptured because of overhydration can't be repaired. We have a degradation of current blood clots is in there. So if we have a blood clot that has started to form within there in an opening in the vessel and everything, it's going to degrade that. And once we remove that clot, then increased bleeding is going to occur. And again, along with that, dilution of clotting factors. crystalloid solutions, as we infuse them, they can leak out of the vascular system and into the interstitial fluids or into interstitial space within 30 to 40 minutes after it's administered. As this leaks out there, it's going to cause an increase of fluid and edema between the alveolar walls and the capillary walls. This decreases the ability of this diffusion process taking place because it has a greater valley that it has to jump in order for this to occur. So waste products and oxygenation can't take place or cannot take place as easily as it does with this increased amount of fluid. If bleeding can't be controlled, one of the things is administer small volumes of fluid to the point that it begins to reverse the signs of shock. Don't just be overloading them with fluids. Initially, the basic rule of thumb is try a liter of crystalloid bolus, warm if possible in there, and then try to achieve and maintain a systolic blood pressure somewhere in the 80 to 100 millimeters of mercury. If you've got a TBI patient, considering an increase it to 100, 120 millimeters of mercury. That seems to be the basic rule of thumb now for treating those patients. If bleeding can't be controlled, we need to get them transported to an appropriate trauma care facility. Again, this is one of the things that white blood is becoming a big product in the pre-hospital environment because of this ability to, number one, have oxygen carrying capabilities that crystalloid doesn't have, and decreases the amount of failure that occurs from overhydration of the crystalloid solutions as it leaks out of the cells into the interstitial compartment of the body. This next slide here. This is my attempt at drawing about the clotting process. So we've got an open here in the vessel, and these are little fibrins that causes the clots in here. So we've got a nice clot here. But as we overhydrate the individual and everything, we degrade this clotting process, and we can burst this clot that's formed there, and again cause increase or a reoccurrence of hemorrhage from that area. So overhydration, again, while it may give you a false sense of security because it will elevate the blood pressure, it's still missing a lot of components in there that's essential for the patient to have adequate perfusion. As we talked about here, as you can see, the results of some of the overhydration again here is it increases, will leak out of the cells that we talked about, and it'll increase this space here, this interstitial area here. And this space between the alveolar wall and the capillary walls become greater. Well, now this becomes harder for oxygen to cross over into and attach to the red blood cells that's in there and the hemoglobin within the red blood cells. But it also causes waste not to be able to be eliminated, again, because you have a high concentration in the circulating blood volume to go back into the lungs to be eliminated. And again, this is going to cause issues in there with increased acidosis. So we're going to talk about, here's what happens, again, as we start seeing hypoperfusion in there. Patient will go into what's known as compensated shock. The blood vessels in the peripheries will constrict. It'll start shunning bloods to the major organs in there. Well, while the major organs may be perfusing adequately, the extremities are not. The extremities are still going through anaerobic metabolism. So we still have a buildup of acid in there from that. And one of the things that's not unusual to see sometimes is when you have a patient that's been in profound shock for a while, once you get them with an adequate blood pressure and hydrated and everything, you might see a flushing of this causing an increased acid back into the body as the circulating volume returns to the extremities and pushing all this acid that is built up in there into the main system. So again, while the major organs are going to do that, it's still increased acid and shivering to produce heat. Now, again, lactic acid initially will be converted into lactate, which is typically metabolized in the liver into bicarbonate and water and then eliminated from the body. But if tissue perfusion increases or worsens, then the body's ability to metabolize lactic becomes overwhelmed. And then it usually results in a profound metabolic acidosis. Acidosis, again, is going to result in cardiac irritability, causing more dysrhythmias, decreased cardiac output. But the other thing is it's going to cause coagulopathy. And coagulopathy is the impairing of the clotting ability. And as the patient's body temperature drops, blood clotting becomes more impaired. So one of the emphasis that one of the areas that we don't always put a lot of emphasis on is on hypothermia. Again, one of the things that we want to do is conserve as much of the patient's body heat as possible. Expose the patient as much as you need to complete your assessment, but remember to recover them right away and remember their head. A majority of our heat loss does come from our head. That's one of the reasons why we wear, hats out in the cold weather and stuff like that. But again, make sure that you conserve as much of the body heat as possible. Move them off the ground or the environment into a warmer condition. Turn up the heat in the patient compartment. Basic rule of thumb, if you as the provider are comfortable in the patient compartment, the patient is not, okay? The patient's not. Turn that heat up, get it up there. Again, as the body continues to become hypothermic, it starts shivering to produce heat. If it continues to shiver, remember, it creates this nasty cycle that's very tough to break. Okay? And the cycle you've all heard too is the triad or the triangle of death, hypoperfusion, acidosis, and coagulopathy. Those are the three things that keep going. It's a dog-eat-dog world in that area there. If we're unable to prevent this, there's a continuous degradation of the cellular function throughout the body. Now, one thing that we're beginning to realize too is there are some studies out there that say maybe this is, instead of a triad, it's more of a diamond of death. No, not only do we have the coagulopathy, the acidosis, and the hypothermia, but the other one now is hypocalcemia. We're thinking the hypocalcemia may have an effect in creating or maintaining this little cycle in here. Now, one of the things that you're seeing sometimes is now you see when a patient gets blood products that they're probably also getting an infusion of calcium too. And that's to combat the hypocalcemia that can occur in their during these stages of shock. Well, here's what's going to happen. We kind of call this a cascading effect of unresolved anaerobic metabolism. So, and again, this is the result of shock. Shock creates anaerobic metabolism. So we have decreased energy production, which causes cellular dysfunction, which causes cellular death, which causes organ death, and then patient's death. And sometimes this cascading effect can't be stopped or altered. What we want to do is intervene as early as possible to prevent this cascading effect from occurring down here. So, in summary, when we're talking about energy production in here or shock, cellular function and perfusion depends on adequate energy production. Adequate energy production depends on a continuous and adequate supply of oxygen at the cellular level. A continuous and adequate supply of oxygen depends on a patent airway, functioning lungs, functioning heart, and intact circulation. Okay. Again, that would be our three main, you remember our pump, our fluids, and our container. All of those have to work in order for us to have an adequate amount of perfusion and cellular function. Interruption of the oxygen supply for any reason will lead to anaerobic metabolism and hyperperfusion. Anaerobic metabolism provides insufficient energy to sustain cellular function for any length of time. Decreased energy production leads to cellular dysfunction, death, organ dysfunction, organ death, and ultimately patient death. That cascading effect. Knowledge and understanding and early recognition of hypoperfusion and impaired energy production resulting from airway compromise, pulmonary injury, and impaired circulation are key to early recognition and treatment of shock. Now, one thing in there that you notice that is the neurological system, because there's very few things that we can do in the pre-hospital environment that's going to assist in that neurological function, except maybe try to prevent additional secondary traumatic brain injuries. Prompt intervention by pre-hospital providers to correct these conditions, along with rapid transport to an appropriate level trauma facility, can help prevent death, prevent the cascading of cellular dysfunction that leads to death. And this will improve the survival rate for patients of traumatic injury. Okay, with that, I want to leave you with one thing that I think that all of us strive to do here. And if you, those of you that know Dr. Nicholas Sen, he was a surgeon who lived from 1844 to 1908. So he came into the business just after the Civil War, but he was also the founder of the American Association of Military Surgeons in the United States. And he summed it up here. And I think that this really lays into what you do as hospital care providers. The fate of the wounded lies in the hands of the one who applies the first dressing. What you do in those early moments with critical patients have an effect on the patient. It may be days later, but it does have an effect. And it's with the important thing in there, what you do first in there. So again, take that in and apply it in there and what you do in your day-to-day business. With that, again, I thank all of you for your time tonight and your attention tonight. And Will, we can, if you'd like, we can open it up to other things that people would like to make comment on.
Thanks, Steve. We have opened it up and don't have a lot of comments right now, but we'll.
That's right. We could talk about anything.
We can. So let's talk about your birthday. Steve gave up his birthday celebration to join us tonight in a moment's notice. So thanks, Steve.
Right.
But I would, while we're, some comments are starting to come in, but Steve, one of the things, I liked a couple of things. One, you got some Normanisms in there, which is like if it's not too hot for you, it's not warm enough for your patient. That was a great one. He always would say that.
Yeah.
But I also liked, at the end of the day, it's like you gave us all the technical explanations about what was happening. But it breaks down into like three things. It's either like a loss of fluid, the container's got a problem, and if you can figure out basically what the patient's telling you about what kind of trouble they're in, plug the holes, support them the best you can, replace fluids if you can, and blood's the only thing that's really going to fix them. All those things are true. But bringing Nicholas Sen back into the conversation, I think, is huge because I think one of the things we lose, and we have a lot of basic life support people that join us here every month. It's really the simple stuff, and it's something that you and I both talk about all the time. It really is that simple. Plug the holes, get them there quick, make sure the surgeon has a chance to do their work. The other things that may or may not be available to you are not the issue. It's doing what you can do as fast as you can. And I'm sorry, I started rumbling there a little bit, but
No, you're right. Especially like you said, the simple things in there. It doesn't do any good if your patient has lost all their blood to start putting blood back in. You have to do those simple things first in there, just as you identified. And we all have a position in there when we deal with patients. It doesn't matter. We hear this. Well, I'm just an EMT or I'm just a first. No, you're not. You're somebody there that can do something in there. The simple things make a difference in between there. Once this patient passes this hump or this plateau and they start down, there's not a whole lot we can do about it. To quote another one of our friends and everything, Dr. Scott Frame, dead patients stay dead.
they tend to.
Yeah, and especially with trauma patients. Dead trauma patients tend to stay dead in between there. So whatever we can do initially to help stop this cascading effect in between there has to be effective in there. We have to give the patient the benefit of the doubt in between there. Do those things. It's the same thing when it comes to transporting the patient to an appropriate facility. Maybe bypassing this closest facility that may not have surgical capabilities or the ability to start a blood product or stabilize a patient and everything is more beneficial to the patient, transporting them a little bit longer to another facility in there. You have to do an assessment of your situation, of your area, know what your capabilities are in there, and base your decision on a valid, continued assessment of the patient.
Yep. We got a comment from an old friend of ours, Norm Roker, out here. Asking
good.
about, and this, Steve, this would be familiar to you as a chopper pilot in Vietnam, as part of your experience. Has there been found to be an effect on altitude on shock treatment? And he referenced the Afghan conflict, but any place where we've got sick people who we're putting them in the air.
Not that I haven't seen anything in there. And again, most of the time that we're going to talk to, that we're going to see a helicopter use, the helicopter is going to stay within a pressurized area and everything. So I don't think that I've not seen anything, and I don't know if anyone else has. I don't know if Dr. Solomon's out there, but I have not seen anything that has indicated any benefit or deficit from that.
I think Dr. Salomon is out there. Dr. Salomon, are you?
Hey, Will.
There you are.
The only thing that I can think of related to altitude is that I think Peter Pons has reminded us on many occasions that they accept like an oxygen saturation of 90% at high elevations, like he is in Denver, Colorado.
Good point.
Right.
Whereas we'd be looking, at lower levels, closer to 95%. But that's the only thing that comes to my mind. I also saw Dr. Wayne on. I don't know if he has a comment about that as well.
Yeah. Yeah. Hi,
Got his
guys.
hand up.
Just having been in that same Southeast Asia place as you, but I trained in Colorado, and we thought normal hematocrits were 55 and 60. So these all folks who came from Leadville, which brings up the point that a quick transition from sea level to altitude may create a problem with the partial pressure of oxygen. So you need to be aware that what would be normal oxygen delivery, a couple liters, whatever, you may have to, one, increase that, and two, you may have to look at more efficient oxygen delivery systems. So just a commentary, altitude affects lots of systems. It affects in fact, our hydrostatic body pressures. So just understanding that effect. And then what's the definition of altitude? Some of us live, I'm sitting in Hood River, Oregon, sorry to say that. But I'm probably on a hillside that's a couple thousand feet almost, maybe 1,500 above the water. That's probably not a significant physiologic change. But those that live in, Vail, Colorado, or Aspen, or Leadville, or more higher altitude, Salt Lake City, as we're getting up, they adapt over about a 3 to 6 week period of time. But our patients that are acutely going to altitude may not be in any way, shape, or form adapted. So there is an oxygen and hemoglobin capacity capability.
So is it,
Long-winded.
Dr. Wayne, with it's a pressure thing, right? Because like us that are flatlanders, if you go down like to the water or up, it's not optimal for the way we're built, right?
Correct. But the other thing is acclimatization. When you go to it and live in an altitude, it takes a period of time because your body, your spleen and other function increase your hemoglobin production. And that's why people in Leadville, their oxygen carrying capacity is increased because they don't have as much oxygen being delivered to them to go to the cells that are there, to then deliver them to the body. So, but it's the acute altitude change, somewhat similar to what we see with diving, where we change, but that is oncologic pressure on the body. We see, and again, dissolved nitrogen that occurs with diving. So physiologically, you don't want to be at the bottom of the water and you don't want to be at the top of the mountain.
Thanks. Interesting too, Steve, you talked about how complex all this is. But one of the things I think that you addressed, the word cascade, I think is a great word for describing what happens to people who have profound injuries and then things start to come apart. And I think the cascade accelerates if that first dressing isn't applied soon enough. If we don't do, again, the basic things. And I hate to keep harping on this because the whole industry is turning on being more technical, more advanced, and giving blood at home and stuff. And I think where I keep landing is we want to get on the front end of that before that cascade takes place. Isn't that what you were talking about earlier?
Right. That's what we need to get in there. We want to try to prevent that cascading because again, each patient's probably going to have a different tipping point in between there. So we have to be aggressive on our in our means in between there. One of the things that always used to frustrate me, and again from some of the textbooks and everything too, was when should you reevaluate, reassess your patient? If you got a critical patient and everything, you may be assessing them full time, reassessing them. Because again, the changes are going to be subtle initially and everything. And what you're looking for is that trending process. Some of the books, well, you wait and do it every 15 minutes or 5 minutes. No, I think a lot of it has to do with the patient. You may have one individual whose sole purpose in there with a critical patient is taking their blood pressure every stinking minute in there. Just again, to try to stay ahead of that cascading effect.
Yeah, I guess basically the way to describe it, I think, obviously the way you described it, but what happens is if you don't get there fast enough, if you don't do what you're supposed to do immediately, if not sooner, stuff unravels. The way the body works unravels. So then if you're doing the right things, but you're doing them too late, it's not going to work because everything starts to come apart.
I see a question from another one of our colleagues, Dr. Meeks. Dr. Meeks is on. Raylon.
Oh, hi.
Yeah. And Raylon, again, I'm surprised she's asking a pediatric question. Is there a difference? Is there a difference in oxygen carrying capability you spoke of on the hemoglobin molecules for a pediatric patient? I don't think so. Again, except for the fact that they have a decreased circulatory blood volume in between there, but I think that the constantly still remains about 40% of the blood is still red blood cells, which then again still should have the same hemoglobin capabilities in between there. But again, they have a decreased circulatory volume in there. So they're the ones that scare me the most in between there. Because you remember, as a pediatric patient, it's going to compensate a lot longer than adult. But when they decline, it's almost straight down. It's not at a bell curve that we'd see with the adult patients in there. So again, Dr. Meeks, I don't have the exact situation in there, but maybe some would. Some of the other our other colleagues would chime in there, but again, I think the key thing is there's decreased body and decreased circulatory volume is going to be one of the issues for them to deal with.
One other thing is Norm Rooker, our friend, asking the altitude questions is because he's working with wildfire crews. Norm, I wasn't clear from your last comment. Did we get to what you were looking for as far as a response to altitude?
Yes, although I may have missed it early. I know the Brits were using TXA with some success, but again, extended transport out of the backcountry versus the urban suburban environment that most of us practice or used to practice in, was just curious about that. I've got folks, most of them at this time of the season have their mountain lungs, but early on I get flatlanders coming up and it becomes an issue. So I really appreciated the values given. It's something I can hand off to my crews that this is what you're looking for.
I don't know if Dr. Salomon has any comments about the TXA and altitude. Do you have any sense of if that's a factor? You might have lost him.
Sorry, looking for the unmute button. I can't even address that. I don't think I've ever come across anything with TXA and altitude.
Yeah, it's the first time I ever heard it either. So I figured let me punt that. And sorry to put you on the spot.
Nothing physiologically is affected that way by TSA. It doesn't work through a process that would affect oxygenation.
Okay, thanks, Dr. Wayne.
Yeah, Marv.
Okay. I have trouble with the first name stuff a lot, especially in front of other people.
Well, but Norm brought up a very good point too, that we forget about sometimes, especially those individuals that work in high altitude areas and everything, is you get the flatlanders that come up there to visit, and they think that they can be as effective on the higher altitude as they are in the lower altitudes. And they can experience some interesting things very early on in there that can create issues for the people that are, especially the rescue groups and everything. It's not unusual to see those individuals go down pretty quick in there. Their mind is writing checks that their body can't cash.
Well, we've made it past 9 o'clock, and I want to be good stewards of everybody's time. We like to keep the conversation going as long as we still get questions from our audience and the participants are able to. I want to thank you again, particularly Dr. Wayne and Dr. Salmo for jumping in and helping us out. It's great that you guys take the time to be with us every month. And actually, it's great that all of you are here every month. You know, we can do whatever we think we want to do, but if you guys don't show up, there's no point. So we really appreciate that you're here every month. Continue to share with us topics that you'd like to see. Consider the rest of our mission, that we're looking for places where we might be able to bring our roadshow to, so we can do conferences in your area. If you know a place, or if you are a place that would like to have a McSwain Trauma Education Project conference, we'd be happy to talk to you about doing it. Like I said, we've been all over the place. We've been in South America and Central America. We're looking at Europe. We've been all over the United States. The idea is so that these kinds of conversations can take place in your backyard, so that your providers who will probably never get to a national conference. We talk about this all the time. Steve and I have been lecturing at national conferences for most of our career, and it's the same people usually that go to these things. Most people don't ever go to these. So Dr. McSwain agreed with us and felt strongly that our mission is to bring this stuff to the communities where most of the people are getting their care from. And if you've got a place, if you have an idea, if you have a question, just let us know. If you like what we're doing, great, let us know. If you don't like what we're doing or you think we're missing something, let us know. This is totally adaptive to what our audience is interested in and what we're trying to do. We want to make sure that you get the information, make things available to you, and we want to interact with you so that we continue to build this into something that has meaning and value to you. Remember that we are a nonprofit. We only exist because people contribute to us. When we go out to these conferences, we generally pay our own expenses. So any help that people give to us help us to do the things that we do. So if you give $1, you give $5, $10, and some places like Mary put up, a couple of people have been giving us thousands of dollars. That's fantastic. It helps us to do the work that we do. We're going to do it one way or another. But if you like what we're doing and you want to support us, again, in for a penny, in for a buck, whatever you got, we'll appreciate that. Thank you again for being with us. This is, Mary, what is this, 4 years now? 4 years we've been doing these every month.
Yep, three. Last month was three years.
So in our 4th year. Okay.
Yes, yes, correct. We're our 4th year.
But just thank you again for participating. I know some of you have been with us all along. We tend to have a large audience from the breadbasket of the country. We really appreciate that because we keep mentioning the basic providers, and we know that that's a big chunk of what EMS is. And a lot of times what you read in the newspapers and what you see in the literature isn't talking about the basic providers, and the basic providers are doing the work, and we want to make sure we're giving you all the tools that you can use. So thank you. Keep coming back to us. Have a look at the web pages, look for our conferences, and if you want us to come to you, we'll come. So get back in touch with us.